Okay, at this time, we'd like to open it up for questions. If you could step to the microphone, identify who you are, where you're from, and if you have a question for one of the specific panelists, please address it to them.
Hi, thank you. This was wonderful. Thank you very, very much. Mary Brady, I'm with the Food and Drug Administration Center for Devices and Radiological Health. Just a comment. One thing I did hear at the beginning that there were people are cognitively and physically compromised. I would like to add also they are emotionally compromised. They're dealing with a new diagnosis. They're dealing with caring for a loved one. They're dealing with a whole lot of things, and hence the remembering of what they've been told is not there, or it's very, very minimal. So if we could keep that in mind as well. We do have a guidance on mobile apps, and maybe you've read it. I see you nodding your head. I think it needs a little bit of tweaking, but at least it's out there, and it's a foundation from which we can start. And the other thing that I keep hearing, and I'm wondering if we can do this here, is to come up with a standard definition of what home health care is. I worked on an international standards committee for medical devices, and from that, I came up with the definition for home use for our purposes in CDRH. And it is looking at wellness. It is looking at a person living with their technology on a daily basis, whether they're at school, at the beach, in transport, wherever they are. So it is not similar to what they have for Medicare. So my question is, can we come up with something that is somewhat standardized for what home health care is? And I would submit that we look at living well outside of a clinical facility with whatever you need to keep you healthy. So if we can look at that over these couple of days, I would really appreciate it. Just comments, no questions. Thank you.
Thank you.
Thank you. My name is Chris Herrmann. I'm with the National Association of Social Workers, and I appreciate all your perspectives. I have a very brief comment and a question. My comment is that I appreciate the attention to transitions of care, and having worked as a hospice social worker, my experience is that patients and families often, once the program is in there, the hospice agency, the home health agency, there's still transitions going on, I think, when every different practitioner in that program goes in. The transition isn't over for the patient and family, and I think a lot of our work as practitioners is continuing to weave those connections together and help people understand that system, even of the one program. So I just wanted to mention that for our consideration. And then my question, I noticed that Trish's slides included a very brief mention of the Jimmo case, and I'm interested, separate from demonstrations for dually eligible beneficiaries that Barbara mentioned, if any of you could speak to observed and anticipated impact of that case and those changes for beneficiaries.
Okay, Tricia would like to see if she believes that there's someone in the audience that could actually best answer your question. Judy?
I mean,
if you'd like. We don't want to put you on the spot, but we already have.
Tricia's very good at that. Sorry to jump to the front of the line. So I'm Joo Dee Stein. I'm one of the lead counsel in Jimmo versus Sebelius. For a while now, so it's nothing personal to the secretary, it's just who's in charge and it changes. And the import, first of all, I can't tell you how delighted I am that people apparently know about Jimmo versus Sebelius, and that is really warms my heart. So I represent people who depend upon Medicare to finance their health care, both people who are older and people who are older or not and have disabilities and qualify for Medicare. And the Jimmo versus Sebelius suit was brought because for the 30 years I've been doing this, the major barrier to access to care in all settings for people who are Medicare beneficiaries is that they're said not to be improving. I'm a lawyer and the law doesn't support that. The law requires in most settings, fortunately or otherwise, that the person needs skilled care, as many speakers have spoken to. But skilled care can be required for maintaining one's condition or keeping you from getting worse, as well as to improve. And Medicare should be covering in a number of settings if other criteria are met and the person needs skilled care to maintain their condition or keep from declining. So that's what JIMO stands for, and I'm very much hoping that home care in particular will be able to be continued as we more and more believe that the law provides for ongoing home care when skilled care is required and the person is homebound and all that other stuff is in place. Even if this went equally for people who need the skilled care, be it nursing or therapy, to maintain their condition as to improve. And while that may seem like it's going to add exponentially to the Medicare costs, that may not be true for a couple of reasons, including that that standard should also be applied in nursing homes and in some instances in hospital settings under the law. It's always been the law. And as CMS now says in the settlement, it's just a clarification of a longstanding policy. So Medicare's home care benefit has not been a short-term acute care benefit since 1980 when the Carter administration removed the 100-visit limitation. JIMOs should help people get what they're entitled to under the law to stay at home, which, if I may, leads to my question to Tricia, which is, do we know whether home care is less expensive than equal care in a nursing home setting? And if not, I think it's a very important thing to know, and I'd be delighted to answer any other questions. I'll be here for 2 days, a reactor tomorrow about JIMO. Thank you.
Thank you so much, Judy. And Tricia would like to actually.
I was going to comment on the transitions statement, but you can see why on JIMO I wouldn't have wanted to answer that question with Judy in the room. It would have been bold and audacious, and you're obviously the source. The issue of cost is a really hard one, and I think there are not good studies that I know of. People have looked at home care as a substitute for nursing home care, but that's not home health. You know, that's home and community-based services. Obviously, full-time care in the home, when we're talking about long-term services and supports, can be substantially more expensive than care in a nursing home. We're not necessarily talking about equivalent quality, but we're talking about costs. I think this is an area where we really need to know a lot more to make the cost argument. And I don't know of studies that are very strong on that point. Can I just comment on the transitions issue really quickly that Chris raised? Because I think we're talking about going from hospital to home a lot. But a lot more and more people are living in retirement communities, independent care facilities, assisted living facilities, something other than nursing homes. And I think the concept of home care may need to evolve to think about better care in terms of, you know, what Barbara was talking about. At least people have a kitchen table when they're home, and they may have family members around. If you live in assisted living, like my dad did with Alzheimer's disease, there's nobody at the kitchen table to really assist with those transitions and to figure out what to do. And I think that is a real flaw and gaping hole in our system.
I just want to emphasize that it's very important to focus on value and not just cost. This comes up all the time. It is easy to cut costs, actually, but you get some really horrific outcomes. So I think the thing that Barbara emphasized and that I mentioned that I consider crucial is acquisition and analysis of the data that can really identify quality outcomes and best practices. And that's something that's a really important part of this conversation, or you'll get the wrong answers.
Mm-hmm. And before we take the next question, I wanted to say something also. As we're sitting here and we're looking at each other, probably 50 to 60% of this audience are users and utilization people. We're utilizing home care. We're going through the same process that our guest speaker went through this morning with aging parents, and we all bring to the table a variety of emotions, feelings, and thoughts about what the model should be. So we should actually think about it a little more, because as we look at each other, we are the users. We're the next users. So we've got to get it right. Next question.
Hi, I'm Andrea Broussard from the American Nurses Association, and like Dr. Newman, I did my dissertation, Predictors and Outcomes of Home Care Use in Urban Elders, New York City, found that intensive home care and New York City in the 1990s was intensive home care, did delay nursing home onset and death for the sickest, which is what we know. But I'm here representing the American Nurses Association, and nurses, particularly nurse practitioner, advanced practice nurses, we've had to do this workaround on the current certification for home health. And we have a bill, and the Home Health Improvement Act, we have the most sponsors we've ever had for it. We can't move it forward. That provision in Medicare that a physician has to certify home health, and even worse now with the face-to-face encounter, that a nurse practitioner, or clinical nurse specialist, or a PA could do the visit, but a physician needs to sign off, which is frankly insulting. But when we brought this bill forward, Congress says, well, if it goes to the CBO, then it'll be much more expensive because of the woodwork effect. You know, you have NPs out there, and there'll be much more demand for home health. And we say there's got to be, in these large home health agencies, there's got to be folks who are doing these workarounds, that the technology, that it gets moved from an NP out in the field doing the visit, then the physician has to sign off, that there's got to be a way to measure some efficiency in that. And the other argument that we often make is, if we could get home health out there sooner, and for our nurse practitioners who are practicing out west, Washington State, they have to pay physician providers to sign the certification, which delays home health. If a NP makes a visit, discovers a decubitus ulcer, a bed sore, orders home health, she has to get a physician provider to sign off on it. There's got to be a way to measure that delay. So I'm hoping, I'm hoping that Doug has some ideas about CBO, and I'm hoping that other folks in the room have some ideas about how could we measure this to make this more tangible, that this expensive workaround that the American Academy of Home Health Medicine agrees is totally inefficient, unnecessary, that we could remove this barrier and increase access.
It's never come up before that people disagreed with the CBO. I'm shocked. There are two generic responses to the problem you identify. Number one, in many instances, there is an intervention, a treatment, a therapy, whatever it may be, that people deeply believe will save money later. And in fact, it's often true, but the way the budgets are calculated, it's 10 years, and often the savings are outside the window, and that doesn't count, and there's nothing CBO can do about that. That's entirely driven by decisions made by the budget committees, and it's an aspect of legislative life. CBO measures costs. If there are benefits, you have to get policymakers to advocate on behalf of those benefits. The second, and a tougher one on the data and the science, is there are lots of individual provider experiences. There are sometimes even successful business models that are not representative of the entire population, which will be served by a Medicare program in particular. And so the challenge is to deliver studies that say, look, for the population as a whole, this approach will generalize and still save money, not just if we somehow get these patients and ignore everyone else, which is a good business model. But that's not what Medicare does. Medicare is for everybody. And so that's your challenge, is to have not just some provider experiences on their populations, but showing that it'll generalize to the population as a whole.
The problem is only going to get more acute. Right now, about 1 in 5 primary care providers is a nurse practitioner. In 25 to 30 years, 1 in 3 is going to be a nurse practitioner. And if we keep having to do this paperwork shuffle, even electronically, it's just a barrier. Thank you.
Thank you for your question.
Hello, my name is Cynthia Boyd, and I am at Johns Hopkins University. I'm a geriatrician who is a researcher, but also I provide primary care. And I would love to hear the panelists comment on what's known and what's changing and how much variability there is in communication between the person that's at the home, at the kitchen table, and the other sites of care. I think both Barbara and Tricia touched upon this. I think it's part of that integration of where home health fits. We have a study in the field that's on a piece of that relating to communication between that person at the kitchen table and primary care physicians. But I think it is an important issue that I'd love to hear the panelists come in on and perhaps hear more about throughout the day.
I can certainly talk about the reality of it. Much of the time of home health is spent with family members trying to explain by phone or at the kitchen table, here's what this means, and here's what you need to do about it, and here's who you need to call when this happens. In multiple languages, in drawings, beyond anything that you can possibly imagine. What we find, though, is the need to have someone to answer the question at the moment that it happens. You can teach at the table all day long, but it's the moment of confusion when they take the pill, when they get up in the morning. And what we're finding actually effective sometimes are call centers that do warm transfers to pharmacies and take care of the problem. Sometimes it's reduction of anxiety, et cetera, but it's the communication at that moment that seems to make the difference long-term in behavior, and then the follow-up coaching, if you will, after all.
Just a little bit of follow-up. I guess I also was interested in, that's great, and I really appreciate that, in how, if there is an issue that needs to be changed, how we can learn how it's currently communicated back with potentially a person in the hospital, potentially the provider in the the outpatient office. Because I feel like that home health care has this unique window to what's really going on and what the issues might be. But I'm interested in how we can make sure that that information is getting back to the rest of the health system so that we can really be helping people make the best decisions and making changes when we need to. I'm sorry if I didn't fully get that second part of my question out there.
No, I think your question is very clear. In some of the ACO practices, in some of the more progressive patient-centered medical homes, I know exactly who to talk to get that information back to. In other instances, who's going to take the call and what are they going to do with the information? I don't know who to call. And that's the biggest gap. Who's responsible for those transitions and staying coordinated across time?
Next question. Thank you, Cynthia. Next question.
I want to commend the panel for your presentations. It was very good and very thought-provoking. A couple of things I would like to suggest. One is that maybe in describing home health care that Medicare covers versus home health care that is out of pocket, because in some of the presentations, if people aren't personally aware of the difference, they may be under the impression that some of the discussion that Medicare is covering. And I will give you an example that is not unique. My father became the caregiver of my mother. My father has polio, is in a wheelchair, and my mother developed Alzheimer's. Medicare only covered for a nurse to come out to check blood pressure. He had to private pay for 9 hours with comfort keepers to do everything else, but he really needed 24 hours. But that was $1,000 a week for 9 hours for someone to help with cooking, bedding, toileting. He ended up telling home health, you're really interrupting my day. Please don't come again. So I think there's a lot of data on home health care provided by Medicare, especially the part about being homebound that people decline. The other thing I would like to suggest, the period of time of mass incarceration has created a growing aging population in the prisons that's even greater than the general population. And a lot of states are shifting costs by early releasing elder prisoners, so the state takes on the cost of care. So the data on these inmates are not a part of our national database. So states have no way of budgeting, if you will. And so it's something maybe to keep in the conversation. Thank you.
I'm sorry, you didn't actually say your name and where you were from.
You're right. Erin Iturriaga from NIH.
Thank you.
I'll make sure not to make that mistake.
Okay.
Mike Johnson from Beata Home Healthcare. So I appreciate the presentation. So one sort of comment, observation, then a question for the group. And the comment and observation sort of builds off the last comment, which is how do we, when you think about home care, what I hear consistently is not all home care is home care. Well, if it's delivered in the home and we're trying to connect with people, it's a lot more similar. And the differences seem to be based on who's paying for it. So to me, if we can talk about home and community-based services, because that's really where we provide opportunity, and agree that we're all sort of talking about the same thing, maybe it's a different provider, I think that would help. And the reason I've been thinking about that a lot is in the Medicare certified home health world, we are considered a post-acute provider. I dislike the term immensely because of what it suggests is we're sitting here with a catcher's mitt waiting for people to pop out of the hospital. How come we're not on the pitcher's mound making sure the pitcher doesn't throw the ball to begin with? So this idea of pre-acute or community-based, home and community-based services, I think that is something we really need to talk about because to me that's where value is. So an observation, I'm certainly open to comments, but my question is, and Tricia, your data supported something I've been thinking about for a long time, and in full disclosure, clinically, I'm a physical therapist, so I think about function. My PhD is in health policy. So my question to the group is, how do we move away or rebalance the focus on disease and drugs and balance it, not to give up on those, but to focus on function and nutrition, and maybe even cognition? And the reason I say that is managing the illness is important, but one of the things that helps manage illness is just getting people moving. The physical power plant are the muscles. Patients who get older, who are sick, and who are bedridden lose muscle mass at an alarming rate, right? Sarcopenia. And so that then affects the ability to heal wounds and do all those other things. But we think about exercise. I'm just saying move more. And that seems to get, we talk about it, but the disease, ICD, and the drugs are really what we spend our time talking about. Every other country talks about ICF, International Classification of Functioning. So I'd love an opportunity to really talk about, we still have to do disease and medication, but how do we broaden it so it's really more holistic, consistent with the WHO definition of health, right? Physical, mental, and emotional well-being, not merely the absence of disease. So I'd love your thoughts on how we do that.
So a couple of comments. I mean, first of all, today I view it as a day to talk about not the programs as they exist, but what the future should look like. And I think it's really important to recognize the programs as they exist just aren't built for the future. I mean, we have a long-term care approach that is ad hoc and has been invented through regulation and minor policy changes. We had a long-term care commission that said, yeah, we need this, but we don't have the money for it. They couldn't figure out a way to pay for it. We have a Medicare program that was designed for acute care stays, now has a population of folks whose biggest problems are chronic diseases. And so I'm with you on the notion that we ought to sort of take outcomes as the focus. We don't care who delivers them as long as they're done in high quality and efficiently. And if it's in the home, let's look at the spectrum of health to activities of daily living and get there. And the functionality that you talk about should be at the focus of it. I mean, there's no doubt about that. The observation is just that this is both important to think about it that way, but it's going to be really hard to get there because it's hard to change federal programs. The way things work now is the information, everything follows the money. So you got to change the money, and we don't have a lot. So you can't waste a lot trying new things. That's the challenge this group as a whole faces.
I agree with everything Doug said. And I'm thinking now I'm thinking a little bit about the money and the Shark Tank that I mentioned beforehand. And I'm also thinking about your comment about pre-acute, getting people earlier to maximize their functional status. And I'm thinking about the Camden model, which I was just hearing more about, and how their intervention is to get people when they go into the hospital. So there is a whole system of care waiting for somebody. The family and patient have been involved in the care plan, so you don't have the experience that Barbara talked about, which is, I'm going home tomorrow. Who's going to take care of me? I've never heard of that home health agency. Okay, I'll do it. Instead, it's much more integrated from the beginning. I'm not sure who the provider should be, and I know there are a lot of people competing for that space, and in some ways it's competing for the dollars. But capturing people as early as possible to prevent functional decline seems like a really important goal.
So just one thing to add to that I mentioned is if we look at home-based and community-based services, Barbara, what you were talking about was really we lack surveillance that could pick up just what you talked about. And so there are very, very few evidence-based approaches that show decrease in costs and better outcomes, but Health Quality Partners in Doylestown, Pennsylvania is one of those groups with a CMMI grant that has really shown that. And it's really old-fashioned community-based nursing surveillance. Whether that could be a non-skilled worker is another question from a cost perspective, but there are some models that we could be thinking about that could start to get at some of that. But thank you.
Just a quick comment. I think you've made an incredibly important statement. Long-term care in this country is considered nursing home, et cetera. Long-term care can't mean that anymore. It just means the reality of chronic disease, aging, disability. And the other incredibly important point you made is community, not just in the home. So it's really health that most often is in the home, but it's within the community. And I'm going to urge participants to look for the new information from Australia and how they've chosen to address that. It is fantastic.
Bruce Leff from Baltimore. Just one follow-up comment on the nature of innovation. Some innovations are old things that we just figure out how to use appropriately. So it's not always an app or a widget or a camera or something going over fiber optics. So I think that's important to keep in mind. Question for Doug. I loved your discussion of the various levels of silos, and I think that's really, really important. And the question is, did you think that there were legislative fixes for this that are actually in the realm of moving through a process, or did you see the breaking down of silos coming out of new business models and getting to 80% penetration of managed care so that we can manage the dollar and think about value in a way that we're not thinking about it now, or other types of payment mechanisms? Is it going to be sort of an evolution that follows the development of new business models, or is it going to be another knife fight in a telephone booth on Capitol Hill?
I think it'll be both, quite frankly. I mean, everyone likes a good knife fight. We'll have that. But I want to echo your point. There's a lot of organizational innovation that's been essential, and we're looking in the midst of that. There was a wonderful slide with all the different care models that people are playing with right now. We don't know which one's going to be the best. So my view of the legislative part of this, where you actually pull levers is to make sure that you allow for payment on the basis of outcome, no matter which delivery model provides it, and let them compete and see who wins. And the only exception to that is in traditional Medicare right now, we have one thing that is not fee-for-service, that's Medicare Advantage. Its great virtue is it's not fee-for-service, and you shouldn't let it go away. And we should build on that and allow the range of things that are reimbursable there to include not just traditional healthcare services, but broader things. And then those MA plans will morph into some sort of a continuum of care organization with a variety of management services that help people. And that's the future. And so that's relatively incremental. But underneath it is a lot of change in the delivery models. But it has to be reimbursable. I mean, in the end, this stuff follows the money, and that's a reality.
Sorry, Amy, you're not allowed to ask any questions. No, Amy's a friend of mine.
Amy Berman, the John A. Hartford Foundation. So I have a comment to add to the depression about the economic forecast. Just one additional piece to add to that forecast. The economic benefit attributed to family caregivers, and mind you, when we're talking about home health that is intermittent or part-time services, is valued at greater than the total spend of Medicare. So it is significant. And what will happen in the coming years as we have this greater acuity, not just the doubling, but people skewing older, and so it will be much more than a doubling in terms of the need. We will also have a significant reduction in terms of the availability of family caregivers, not just employees that are contributing to the trust, but in terms of those numbers of family members that simply are available, not necessarily willing or able, but simply the numbers of people available to be family caregivers. So one thing that I would challenge us to think about is what is our opportunity to optimize the ability to build on a platform that will look very different in terms of working with family caregivers. Today, from a policy perspective, the unit of care is the beneficiary. It is not the family caregiver. So how might we begin to perhaps think in a way to optimize the value proposition and be able to support that infrastructure at home so that people are able to stay out of higher cost and shall I just say, undesirable care for many? Love to get your thoughts.
So I think you said better what I've worried about for a decade, which is, you know, it's baked into the demographics that we're going to have the population that needs care rise, the population that provides the vast majority of care shrink, their time to provide care shrink, and what do you do? So you've stated the problem beautifully. I don't know the answer. I really don't. We have seen a variety of experiments that have collapsed. We tried the Class Act. It doesn't add up arithmetically. We've tried some partnerships for long-term care, private insurance. No great success rates there. We have a deep problem, and I think the key to solving it is to get away from the silos. We've always thought of this as let's have a solution to this piece, but in fact, it's about this broader range of services that are going to be required and the outcomes that we want that we need to focus on. So we've tried the silo approach and failed a couple times. I think we've got to give that up and rethink the whole process. That's the only observation I have.
Just a thought, and it sort of picks up on what both Barbara and Doug were saying. There is more interest in capitated systems, and there is interest in the duals model, and there's interest in Medicare Advantage and managed long-term care services on the Medicaid side. There still isn't a lot of evidence, and there probably won't be a lot of evidence on the duals demos for really many, many years. And even on Medicare Advantage, while it's been around for a while, there's not a lot of evidence, as far as I know, about how well managed care plans are taking care of frail older people. We know from the literature that managed care is doing probably a better job on preventive services than traditional Medicare. But we're not talking about the average. We're talking about seriously impaired people. And so I think we need to get more evidence about how well those systems are working for seriously impaired people before we are confident or move in a direction or think that managed care and capitation will be a solution for care, even though it may be clearly a solution for budgets.
I have time for one more question.
Hi. Terry O'Malley, Partners Healthcare, Boston. The question really kind of comes after your two comments, and that's, so where is the financial stream that's going to drive these changes that we've all been talking about? And one of the hopes was that realigning healthcare payments to the ACOs and managed care organizations was somehow going to create a sudden awareness of the importance of the social determinants of health and the value of home and community-based services. And yet that doesn't seem to have necessarily followed as quickly as we had hoped it would. So what are your thoughts on how that gap gets bridged? I think if we're waiting 5 or 10 years for the data to come in, we're going to be over the bridge a long time, waiting for the data.
Nothing happens quickly, as it turns out, I think. So I would counsel patience to some extent. It's the experimentation issue, I think, more than anything else. I mean, you know, if you allow these models to play out, we're going to find out which ones take advantage of these factors to reduce the cost, increase the quality, and get success. And that, I've, you know, I understand the Affordable Care Act is a highly contentious issue, and I have strong views about it, but it's important to recognize it was the beginning, not the end. And this is going to go on for a long, long time. This conversation is part of getting it right in the end. And so I don't think there's going to be instant awareness of anything. There's going to be a lot of experimentation, a lot of churn, and we're seeing that right now. There are a lot of these, I would echo what Tricia said, we've seen no particular dramatic success from any of these things to date, but there's some promising stuff out there. I think the dual demo is extremely promising. It's one of the things I'm most hopeful about, but you know, we haven't made the case yet. That's why I just think it's a mistake to pick one model and say, gee, we got it. I mean, that's never a good idea. It's better to, you know, let 1,000 flowers bloom and support those that are successful. And that just takes a lot longer.
Okay, well, that concludes our panel. I want to thank Barbara, Tricia, Doug for such an awesome, thought-provoking panel. You did a great job. Please join me in thanking them. And I'm going to turn it over to Bruce now.